The Pseudomonads consist of a number of different genera that are all fairly closely related, which is why they are grouped together. We're not going to talk about all of them, but we are going to talk about some major potential pathogens that you could see, especially in the States. So Pseudomonas aeruginosa is the first bacterium we're going to talk about. Pseudomonas is the genus, so Pseudomonas aeruginosa is the species. These are gram-negative rods that you can see here. So these are all the bacteria. They are found everywhere. This is a very, very ubiquitous species of bacterium. Actually, really the entire genus is pretty easy to find. Some species of this genus are important for plant growth and development. So again, they're really common in the soil. These bacteria, though, are generally not part of the microbiome. Usually when people have this bacterium, it's because they have an infection. They have very simple growth requirements. They will grow in some of the most minimal media I've ever seen. This is a bacterium I work with quite a bit, and it tends to contaminate everything. They are aerobic, and they are oxidase positive, again, which helps differentiate them from the gram-negative rods of the Enterobacteriaceae. They produce a number of different pigments that have various effects. Piocyanin is one of the major ones that we'll talk about because it's a toxin that the bacteria produce that can cause host cell death, but they have many other virulence factors as well. Some of those virulence factors include adhesion. They can use flagella, pili, LPS. They secrete carbohydrate compounds like alginate that help them form these really, really robust biofilms. Some of their secreted toxins and enzymes, they secrete a toxin called exotoxin A that disrupts host protein synthesis. They secrete that piocyanin, which produces reactive oxygen species to cause host cell damage. And that piocyanin is this kind of blue-green color. So a lot of Pseudomonas cultures and Pseudomonas infections can be diagnosed by the color. Pyoverdin, one of the other molecules they secrete, helps them to sequester iron. They produce a lot of different enzymes listed here that help facilitate tissue destruction. And they have enzymes that they secrete into host cells using a type 3 secretion system to kill those cells. And if that weren't bad enough, they have a lot of intrinsic and acquired antibiotic resistance. So even laboratory strains of this species are pretty drug resistant. Where we tend to see these infections a lot are in our hospitalized patients and our patients who are immune compromised. And in our hospitalized patients, these are really common in burn and surgical wounds, but we also can see pulmonary infections, especially in patients who have cystic fibrosis. So the bacteria can cause infection literally anywhere in the body: pulmonary infections, skin infections, urinary tract infections, ear infections, eye infections, bacteremia. It's a really dangerous infection, and it's really, really common. In this patient, this is a patient who died of a Pseudomonas infection. You can see the necrosis caused by the bacterium. This is a patient who has folliculitis, or infection in the hair follicles caused by Pseudomonas. And so here's a case study of folliculitis caused by Pseudomonas aeruginosa in guests of a Canadian hotel. A guest complained of a skin rash that had papules, and then they became pustules all over the abdomen, buttocks. For most patients, the rash resolved spontaneously. The local health department investigated and determined the source of the outbreak was a whirlpool, or like a jacuzzi, contaminated with high concentrations of Pseudomonas. The outbreak was terminated when the whirlpool was drained, cleaned, and superchlorinated. So basically this bacterium was just hanging out inside of a jacuzzi. There's not a whole lot of nutrients in there, and the bacterium was doing just fine. So skin infections like this are common in individuals with extensive exposure to contaminated water. And again, I mentioned burn wounds, and we have the burn wound patient here. This is one of those infections that if a patient gets this in a burn wound, especially if they have a significant burn, it is fatal a lot of the time. So I worked on this bacteria a lot as a postdoc, and my postdoc advisor at one point, I worked with the U.S. Army at Brooke Army Medical Center in San Antonio, which is a big burn hospital for both Army and civilian. And our PI had been called down to the autopsy to get some bacterial samples to kind of figure out what the patient had died of and all of that. And I think she had like 35% total body surface area burns, which is significant, but not nearly as high as we've seen. And everywhere that she was burned was green because of a Pseudomonas infection, and it just took hold and killed her very quickly. So this is a really dangerous infection, and if you do find yourself working with burn patients, you have to keep very close observation on them to make sure that they don't get this infection. I thought this headline was rather interesting. About 5 million bottles of Fabuloso, which is a cleaner, were recalled because of bacterial contamination. And so you see this is from February 2023. So normally the cleaning products have a preservative added to them to help stop bacterial contamination. They're not saying it wasn't added, but they were saying it wasn't added at intended levels during manufacturing. So the bacteria can grow in cleaning supplies. Another place that this bacteria is really commonly found in hospitals is inside of soap dispensers. So it will form a really robust biofilm inside of a soap dispenser. And so, a visitor or healthcare professional is going to that soap dispenser, dispensing some soap and washing their hands and literally coating their hands with Pseudomonas before they go visit a patient. So it's a really, really dangerous bacterium. They will grow in lots of different kinds of media. Like I said, they're not picky. They'll grow in Fabuloso, they'll grow in water, they'll grow anywhere. They are aerobic, so they tend to grow near the air-liquid interface. And like I said, they do form biofilms. So often when you're growing Pseudomonas species in culture, if it's a liquid culture, you'll see like a pellicle formation. So you'll see that biofilm form right at the top. There's also Pseudomonas isolation media that will preferentially or selectively grow only Pseudomonas species. They grow very rapidly, so if you swabbed a patient, you could see colonies the next day. They are beta hemolytic, so you could see that on blood agar. They are green usually, especially on Pseudomonas isolation media, but even on nutrient agar, there's a blue-green tint to the colonies because of that pyocyanin production. And they smell. The bacteria smells like, in my opinion, it smells like a grape Jolly Rancher or grape cough syrup or grape Tylenol. It's that artificial grape flavor. One of my friends who grew up in Texas and worked in the same postdoc lab as I did, he said that to him it smelled like corn tortillas. So honestly, it does kind of smell like corn tortillas, but I really like corn tortillas and I don't really like fake grape stuff, so I'm going to pretend it smells like fake grape, but it's a pretty noticeable odor. It can be treated with combination therapy. Remember, there's a lot of intrinsic and acquired antibiotic resistance, but of course, infection prevention is going to be key here. And so the CDC does consider multi-drug resistant Pseudomonas aeruginosa infections to be of serious concern. It's estimated that in 2017, there were over 32,000 cases and nearly 3,000 deaths, with $767 million in healthcare costs associated with this infection. Very briefly, another genus to talk about that's very closely related to Pseudomonas, in fact, it used to be considered as part of Pseudomonas, is Burkholderia. And the reason that I talk about Burkholderia is because this organism, Burkholderia sapaceae, and very closely related species, cause opportunistic infections, generally in the lungs, particularly in patients with cystic fibrosis. And if you ever find yourself as a healthcare provider for someone with cystic fibrosis, you really have to do everything you can to keep them free of this infection, because if they have it, they cannot get a lung transplant. And a lung transplant is the only permanent treatment for cystic fibrosis. So once they've had this infection, they almost can never clear it, which means they cannot get a lung transplant. Another species of Burkholderia pseudomallei, causes a disease called melioidosis. Pretty rare. It causes a cutaneous infection that can go septic. It can also cause pulmonary disease that can be mild all the way up to necrotizing pneumonia. But again, most commonly in a healthcare setting, you're looking at the Sapaceae complex that's going to be affecting your cystic fibrosis patients. So it is absolutely critical that you prevent this infection in them. And you generally don't want to keep cystic fibrosis patients hospitalized in the same room, because if one has Burkholderia, the other will get it. One way you can differentiate between the two, Burkholderia and Pseudomonas, because they're almost identical. They're going to look the same under microscopy. They're the same biochemically. Burkholderia is susceptible to trimethoprim sulfamethoxyl. Pseudomonas is resistant. So if that drug kills it, you've got Burkholderia. If it doesn't, it's Pseudomonas. Another genus to talk about that is not as common but tends to be very, very highly drug resistant is Stenotrophomonas. There was a documentary that came out a few years ago on like PBS and Netflix, and it's called something like Hunting the Nightmare Bacteria. And this was one of the bacteria that they featured because it is so highly drug resistant. Again, it's not super common, but once it gets into a patient, it was very, very difficult to clear. And so this is an 8-year-old Chinese girl, and they mentioned that because it was a patient, I believe, in China. She had acute myeloid leukemia and a complex history of recurrent fungal and bacterial infections during the course of treatment for leukemia. So remember, leukemia is a cancer of the white blood cells, and one of the best treatments is chemotherapy, so that also causes a decrease in white blood cells, which makes patients very susceptible to infection. She'd had aspergillosis, which we'll talk about in the fungi, Klebsiella, Enterobacter, Staphylococcus, Streptococcus, Bacillus, right? Tons and tons of infections. While receiving treatment with meropenem and amikacin, 2 different mechanisms of action, and during a period of severe neutropenia, no neutrophils, she became bacteremic with Stenotrophomonas multifilia. So she's already on 2 antibiotics and she got this infection. So it's really, really dangerous. However, it is sensitive, or this strain was, to trimethoprim sulfamethoxyl, or TMP-SMX. Over the next few days, she developed painful red skin lesions. The bacterium was isolated from a biopsy of the lesion. Intravenous antibiotic therapy with the trimethoprim led to the gradual reduction of the skin lesions. This case illustrates the predilection for Stenotrophomonas to cause disease in immunocompromised patients receiving carbapenem antibiotic. So it's resistant to carbapenems. Characteristically, Stenotrophomonas is one of the few gram-negative bacteria that is inherently resistant to carbapenems and aminoglycosides, but susceptible to the TMP-SMX. So this, again, I really want to highlight this genus as this infection took hold in a patient who was already taking 2 very strong antibiotics, but it is inherently resistant to them. So that's a very, very dangerous infection. The last pseudomonad we'll talk about is the genus Acinetobacter. These are saprophytes that are able to survive on moist and dry surfaces. And the species that we worry about the most is Acinetobacter baumannii. This causes most human infections. And it's an opportunistic infection. Basically, wherever it gets in, it'll cause an infection if it can: wounds, urinary tract, and respiratory tract. People have called this infection Aeruginosa because it is an infection that we did not commonly see in the United States until soldiers who were wounded in Iraq started coming home. And so what we would see is that wounded soldiers back from Iraq, when this was in the most recent conflict in Iraq and Afghanistan, would come home. They would be wounded in combat, and combat medicine has gotten to the point where 90% of soldiers wounded in combat will survive the initial wound. The challenge is getting them home without an infection. And so when you talk about perhaps they were wounded in combat in Iraq, they have to be evacuated to one of the major bases in Iraq, which could take a couple of days. Then they get evacuated to Germany, usually. And then they would get evacuated from Germany to Walter Reed in the US, or maybe BAMC, which is in San Antonio. And that could take anywhere from 7 to 10 days before they get to the US. But in the meantime, they're just having drugs thrown at them to try to keep them alive. And so what happened was, as these soldiers were wounded, this bacterium was found in the soil in Iraq. It was getting into their wounds as they were wounded, and they were just being exposed to antibiotics constantly. And so these infections became multi-drug resistant. So soldiers wounded in Iraq are coming home with multi-drug resistant Acinetobacter, and several strains have spread within military hospitals. So cases of multi-drug resistant Acinetobacter baumannii started to appear along the medical evacuation routes from Iraq in March 2003, with infections noted on the U.S. Naval Hospital ship Comfort and at Walter Reed Army Medical Center. And this was back in 2005. More than 250 cases have been identified, including 18 documented cases of nosocomial transmission to non-military patients receiving care at U.S.-based military hospitals. 5 of those civilians died. And so again, this is something that we weren't even talking about 20 years ago. Well, we started talking about it about 20 years ago. And since then, it has now become an urgent threat in the United States. Carbapenem-resistant Acinetobacter. 8,500 hospitalized patients, 700 deaths, with almost $300 million in healthcare costs. These bacteria can survive for a very long time on surfaces, and these infections are almost certainly acquired in a hospital setting. Almost all the patients who've had them recently received care in a healthcare facility. So this is, again, really trying to highlight to you as a potential medical professional how important it is to control infection within a hospital setting. So those of you who are interested in medicine, if you're going to be working with patients, you have to do everything you can to keep the environment around you as sterile as possible. So this is a military superbug, but a quiet civilian epidemic. And then again, Acinetobacter infections associated with the war in Iraq, unusual cases. So these are things that you'll have to consider and think about as you work through your career in human medicine.